Let me just ask you a couple of opening questions. Artemisinins, the power of that very important drug to help cure people with malaria has been maybe thrown a huge curveball in, as I said earlier, in Cambodia, Burma, and particularly along the Thai border. And my question is, there's 104 malaria endemic countries. Obviously, and you know because you've been a part of this, we went from $100 million in the year 2000 to $1.8 billion worldwide in 2012. Certainly below what the target was if we wanted to really look to eradicate this horrible disease. But how concerned are you and CDC about this problem? I know WHO talks about containment and trying to ensure that this is not spread to other places, particularly Africa, where it would be even more catastrophic. If you could spend some time on that, I'd appreciate it.
Thank you. Thank you very much, and thank you for your support for the President's Malaria Initiative. I've seen, as you have, this program in action in Africa and elsewhere, and it is breathtaking. I've gone into communities that previously had extensive amounts of malaria. CDC has documented that in some of these communities, 1 out of every 4 medical visits of children was for malaria. 1 out of every 2 units of blood used for transfusion was for malaria. And in communities where they've implemented good control measures, we've seen essentially 0 cases of malaria with good control and 0 deaths. So we know that tremendous progress is possible. We're quite concerned about artemisinin resistance. We've seen areas, as you say, in Cambodia and elsewhere, where as many as 30% of patients have evidence that their particular strain of malaria is responding much less well to the artemisinins. This is our last hope for good malaria control. We have to preserve this drug. I think you can think of drug resistance and prevention of drug resistance as something that we owe the world, we owe our children, that these antibiotics that we've been bequeathed by people who worked so hard to come up with them are preserved and can be used to protect lives for many years going forward. What we think is possible is first to understand better what's happened, and second to contain as well as possible through a comprehensive approach to vector control, that is, stopping the mosquito, treating effectively, diagnosing and treating well. And I think overall with malaria, we're quite reassured by the overall amount of progress that's happening. The challenge with malaria is the challenge of persistence. We've seen big progress with malaria before. We let up our guard and it came roaring back. Yeah. That's exactly what we have to avoid. We have to intensify our work in Southeast Asia to understand and contain artemisinin resistance. At the same time, we have to scale up the core malaria control interventions in Asia and Africa especially, so that we can reduce the number of deaths and the burden of illness. There's still a lot we know that we're not doing, and we need to scale up bed net use and high-quality diagnosis and treatment. There's still certain things that we know, but we don't know, that we need to understand better about the malaria parasite, about the best tools to control it.
And isn't it true that about half of those who should have bed nets have it, but we are running into the problem of the bed nets now losing their efficacy to keep the mosquitoes out? So we need a replacement effort as well.
CDC scientists have looked at this carefully. The life of a bed net is not an easy one. They get embers put on them from the stove. They're worn out, and so having the first set of nets out was great and knocked down child mortality enormously. We've documented at CDC overall reductions, not malaria specific, but overall reductions in child deaths of 25% just from the malaria control program. But exactly as you say, Mr. Chairman, the nets now need to be replaced, and that requires resources.
In terms of drugs that are actually in the pipeline, we know that newer orders of new types of antibiotics are few and in between. On tuberculosis, without objection, we're including testimony from Dr. Adrian Thomas from Johnson & Johnson, and he points out that Janssen is bringing forward a new medicine specifically indicated to treat a drug-resistant form of tuberculosis. It's called Serturo. It seems to have gone, or it has gone, to the next stage, although it's not used yet. My question on that drug specifically, and other drugs that are or not in the pipeline, particularly as it relates to malaria and multi-resistant tuberculosis, multi-drug.
I think a key concept is that the development of new antimicrobials, new antibiotics, is a necessary but not a sufficient condition. Now, for those two conditions particularly, we're very encouraged. It's the first new anti-tuberculosis drug in decades. We think at this point it should be reserved for people who, for whom other drugs are not available. The CDC has convened national experts to look at what is the optimal way of using this new drug. We'll need to have some clinical trials. And the FDA moved very quickly to approve it so that patients could get it and their lives could be saved. There are some other drugs for tuberculosis that are in the pipeline that are somewhat encouraging, but what we know is unless we improve our treatment system, we will lose those drugs as well. In terms of malaria, the situation is perhaps a little less encouraging because virtually everything in the pipeline is either an artemisinin-related product, a synthetic artemisinin, or something that has the same resistance mechanisms as the artemisinins appear to have. So if we lose the artemisinins, we may lose the new drugs before we even get them. I think this comes back to one of the core concepts of antimicrobial resistance. Resistance develops because of poor quality programs. It's very straightforward. If you have a good quality program, you will not get lots of drug resistance. And in tuberculosis, which I worked in for many years, one of the core concepts is that a poor quality program can create multi-drug resistance faster than a good program can treat it, no matter how many resources you have. And it's critically important to stop resistance from emerging and then to stop it from spreading. We documented in New York City in the early 1990s that as many as half of all of the multi-drug resistant tuberculosis patients had actually caught it in the hospital. So hospitals can become an amplification point for drug resistance. That's why in our work in this country and our recommendations to other countries, we've advocated a program called Detect and Protect. Detect and Protect. It's a simple concept. Find the patients that have the resistant organisms, protect them from harm with it, and protect other patients from getting it from them. And one of the things that we're encouraged by is the amount of progress in things like methicillin-resistant Staph aureus, where since 2005, we've documented a more than 50% reduction in the serious infections with that highly resistant organism. This is not a problem for which we have no solution. We know what to do. It's a question of doing it. We also need some new knowledge, but what we can do now is a much better job at reducing the risk of detecting it, so we find the patients who have it, and of protecting others from them and protecting them from the organism.
Dr. Frieden, you've made a very strong appeal to Congress to include in its budget what is in the FY 2014 President's budget for the Advanced Molecular Detection Initiative. As you point out, it combines two powerful technologies, molecular sequencing and bioinformatics. Could you perhaps elaborate on exactly how that works? And if you could also, and then I'll yield to my colleagues for their questions, speak to the area of labs, which you made reference to. How much connectivity is there with CDC and those labs? Are they at a basic level? When I travel, I always ask about the labs myself. Matter of fact, we had a hearing in the last Congress with Cure International and the magnificent work they're doing with infection-based hydrocephalic condition. And they have cured over 5,000 children in Uganda alone with a simple intervention that does not require any stents. It doesn't require, the kind of follow-up that we often would need here, but it is infection-based, they believe. And I watched one of the operations myself. The lab you mentioned in Uganda, I'm not sure if that lends itself to the kind of detection that they need to do on this, but the labs, where are they, particularly in Africa, but elsewhere in the world? How do we grow those labs as well as their sophistication and their connectivity to you?
Thank you very much. The Advanced Molecular Detection Initiative would give our top quality disease detectives the cutting-edge tools to find problems and stop them sooner. We have terrific scientists at CDC. We have a mandate within this country and abroad to detect and stop problems. But our hands are in some ways tied because we can't look into the microbe's genome in the way that technology actually allows us to today. To give you just one example of that, with H7N9 influenza, which we can talk about more a bit later, we're very concerned to see, will it develop the capacity to spread easily from person to person? So far, we're confident it hasn't. If it does, it has major implications for all of us and for every country. We think we could learn more if we could go into clinical specimens and sequence the entire genetic material in those specimens. What happens when you grow an organism is that one particular strain grows very well, and you can analyze that in the laboratory. But that's not actually what's happening in the patient's body. What's happening in the patient's body is that there are many different, an assortment of different substrains, or what are sometimes called quasi-species, of that organism. And by sequencing from there, you can figure out what is going to happen. You can skate to where the puck is going, not where the puck is. AMD, advanced molecular detection, would allow us to do that, not just for influenza, but for other organisms as well. It's a critical tool in helping us not only avoid problems, but prevent them in the future. The laboratories were very encouraged by the progress around the world. I think there are two broad areas where we're going to see more progress. The one is what are called point-of-care tests, things that a doctor or nurse or other health worker can do at the patient's bedside or at the patient's hut side. Things that use a dipstick, as we're using in Uganda with plague now. So these are great technologies because they take not much time, they're highly accurate. It's how we're diagnosing HIV and malaria now in the field. The other are the high-tech things, where we can go in and look at a specimen, and there are now technologies which can look at 24 different organisms to say, in this one specimen of blood or sputum, which of these organisms are present. We've already used this on an experimental basis, for example, to look at an outbreak that we couldn't figure out what was causing it. And to our surprise, it was a yellow fever outbreak. And because of that, we were able to do control measures. So there is the ability to bring these new technologies to bear on laboratories throughout the world. The African Society of Laboratory Medicine, which PEPFAR helped to start, has made really progress by leaps and bounds. In fact, the Ethiopian government has given them, the African Union has given them free space. Countries all over Africa are doing more with that. In Africa, they're being very willing to do regionalization, so that not every country needs to create everything. It's not efficient. They can work regionally very effectively. Our polio labs, our measles labs, our influenza labs, our foodborne labs are a global network where all of us are safer if every country can do a better job finding and tracking things.
Before I yield to Ms. Bass, is there an inventory of all of those labs that could be made a part of the record and would give us a better sense of, and it also would be a place that when we do travel, we will visit?
We will certainly get you what we have in terms of an inventory. I'll also mention that Congress requested that CDC do summaries of CDC's laboratory work last year and this year. So we have 2 reports on laboratory work that CDC does in this country and around the world, and we'd be delighted to share those, as well as the global laboratory network information.
Thank you so much. Ms. Bass.
Thank you.